It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. I just had an amazing weekend in London with the ISPN team as well as SOMOS, which is like an IPA in New York. I was flown out there to speak to them about pain management for primary care, and it just so happened the same weekend as the ISPN lab, so I really got to bounce between two conferences that were very unique and different in their own way. And the funny thing is, when I was at the primary care conference, I was telling them all about the other conference with my lecture, and I had like 50-something slides, and only one slide was on opiates. And when after my talk during the Q&A, of course, these primary care doctors are going to start asking me about opiates and what to do. And I basically said to them, I said, look, interventional pain management has moved away from opiates. We're being able to treat patients without opiates. And therefore, one slide out of 50-something slides was devoted to opiates. And it's something that does have a place, and a small percentage do get opiates in our practice, but it's becoming less and less common because there are so many great ways to treat pain. And if you're in primary care and all you have really at your disposal are opiates, well, consider sending the patient to a pain doctor. And that pain doctor may not take over the opiates, but at least they can try to treat the pain. And if that doesn't work, maybe you have a leg to stand on if you get accused of writing opiates without fully offering them all the other options. Anyway, at ISPN, I had a great time. I met these doctors from all over the place. Most memorable, I would say, are the London doctors and the Iraqi doctors, because there was quite a few of each. I'd say, aside from the Americans, they probably represented in the largest numbers. And it's really interesting to hear how doctors from around the world treat pain, which is not so different than the U.S., but they have different tools. There's a lot more phenol in other countries that's being used because RFA is not as available. And regenerative medicine has different restrictions in different countries. So there's a lot of variabilities with practice styles, with everything. But I had the opportunity to teach there and learn. A lot of these other doctors from other countries are very knowledgeable and very good, and some of them only have an ultrasound at their disposal, so they are quite talented. And I just want to say that was really a pleasure to be there, to meet everybody. Announcements. I hung out with Sudhir Diwan, who runs Latin American Pain Society, as well as the New York, New Jersey Pain Conference. That is coming up in November. NRAP Academy will have a place there. I personally may not be able to attend, but stop by the booth, check us out. Check out the conference. Sudhir runs the State Society conference that is bigger than many of the national conferences. It's fantastic. He brings in speakers from all over the world, and now that he started the Latin American Pain Society, he's bringing in a lot of talented doctors from Latin America, such as Victor Pacheco, who's from Brazil, and was at ISPN giving a great talk on regenerative medicine. So I have a very busy calendar ahead. We run IV ultrasound placement workshops in New York, and we have one a month. In addition, we have the regional anesthesia and ultrasound guide interventional pain medicine workshops in New York on December 13th, January 10th, as well as in Florida, most likely Fort Lauderdale or Hollywood, November 8th, and then a couple in Detroit, January 18th and February 15th. Hope you guys can make it there. If you can't, you could always do the ultrasound course online. Just go to the nrappain.org website or just type in pain exam. And then we run shadowing opportunities at any of the sites I work at, where you could come and watch us do interventional pain procedures and sometimes regenerative medicine. So email me about that if you're interested. And anyway, this podcast today, as you probably know, I'm really interested in regenerative medicine, and I'm always looking to learn more. I saw a post by Dr. Centeno, who is really well known in the world of regenerative medicine. He's at the forefront. I don't really personally know him. I've seen him speak once, but anyway, he has this great article with a few other doctors, Dr. Berger, Markle, Pell, Murphy, and Dodson. And I like this article because it's well thought out of. I'll have the show notes with the link, and there's some pictures on how they did the injections. So it's titled Non-Surgical Treatment of Anterior Cruciate Ligament Tears with Percutaneous Bone Marrow Concentrate and Platelet Products versus Exercise Therapy, a randomized controlled crossover trial with 2-year follow-up. So surgery remains the prevailing standard of care for patients with ACL tears, but it has a risk, and I'm talking about complete tears. The aim of the study was to compare non-surgical autologous bone marrow concentrate with platelet products compared to exercise therapy for partial and complete non-retracted ACLS tears without meniscal injury. It was a randomized crossover trial. Patients received either exercise or injection of bone marrow concentrate with platelets to treat the ACL tears. After 3 months, if patients randomized to exercise group and they were not satisfied, they could cross over to receive the bone marrow concentrate treatments. Patients' reported outcomes were completed at pre-treatment 1, 3, 6, 12, and 24 months of numeric pain scale, the International Knee Documentation Committee Subjective Knee Pain Form, Lower Extremity Function Scale, or the LEFS, and a modified single assessment numeric evaluation. MRIs at pre- and post-treatment were assessed using J-software analysis. Complications and surgeries were assessed at each time point. To get to the point, the results were that the patients in the BMAC or BMC group reported significantly greater changes in scores from pre-treatment on LEFS to P of 0.27, to SANE, S-A-N-E, to P of 0.007 at 3 months compared to the exercise group. No significant differences were found between baseline and or 1 month and 3 month follow-ups for any outcome measure in the exercise therapy group. When followed through 2 years, patients who received the BMC treatment demonstrated sustained improvement in function and decrease in pain, and patients reported a median subjective improvement of SANE of 90% at the final follow-up. Significant negative correlations were found between age of injury and the changes in the scores. They concluded significant improvements in function, pain, and overall improvement in patients receiving BMC, and platelets provided evidence of viable alternative treatment options for patients with ACL tears. Now, this trial did not compare it against surgery, so that would be also interesting to note. But more and more people want to avoid drugs and surgery these days because patients are getting smarter. If you're a pain doctor, you're probably, we hang out with, I always tell my patients, a lot of people do well with surgery, but we hang out with the failures, those who don't. So we're a little biased, at least I am. I try to avoid surgery whenever possible, and if you can avoid surgery for the knee, then so be it. I myself had 2 knee surgeries, and the second one I questioned if I really needed it, and those were meniscus repairs, and there are a lot who say that that can lead to more arthritis as well as earlier need for joint replacement. Anyway, just a little background and introduction. ACL is a crucial stabilizer of the knee joint, preventing anterior translation of the tibia and restraining tibial rotation. The ACL injuries are common, with over 400,000 ACL reconstruction surgeries performed each year in the U.S. That remains the standard of care. However, surgical approaches have limitations, risks, possible graft failure, tear, persistent instability, cartilage injury, and arthrofibrosis. A big concern is the development of knee arthritis, and extensive research has established a markedly elevated risk of osteoarthritis in knees with ACL injuries when compared to uninjured contralateral knees, underscoring the long-term consequences on joint health. I mean, it's almost like the spine, right? The more you do surgery, the more you have to do repeat surgery. I think standard of care should be to try a regenerative medicine treatment like this prior to going to surgery. However, unfortunately, it's not covered by insurances, and it's still not standard of care, but it's probably best care. Anyway, return to sport is primary driving factor for many patients seeking to undergo the surgery. However, 1 year return to sport rates vary considerably, ranging from 33 to 92%, with systematic review of the literature reporting a post-surgical return to sports rate of 81%. Return to pre-injury level of 65%, and return to competitive sports level of 55%. Given the complex nature of the surgery, associated risks, they want to find alternative options. So PRP and BMAC, or BMC they call it here, it does treat a lot of musculoskeletal pathologies, and they have cytokines, exosomes, growth factors that are believed to initiate cellular signaling to help mobilize a healing cascade. BMAC contains a population of connective tissue progenitor cells, commonly referred to as mesenchymal stem cells, MSCs, which are thought to utilize paracrine-mediated effects to provide benefits in skeletal tissue healing and repair. The promise of healing native ACL lies in the potential to preserve the natural orientation, knee kinematics, and proprioceptive properties. Encouraging results from animal models incorporating BMAC into scaffolding matrices for ACL repair have fueled interest in clinical application. And I'm reading from this article. There are several randomized controlled trials of BMAC used in combination with surgical graft reconstruction showing improvement on MRI, ACL signal at 3 months, improved function at 9 months, others showing decreased laxity at 6 months. Wang provided evidence that injection of allogenic human mesenchymal precursor cells following ACLR improved symptoms and halted joint degeneration, helping prevent secondary osteoarthritis. 2 case series utilizing BMC combined with PRP via percutaneous injection of the ACL tear without surgical reconstruction have reported increased ACL integrity functional improvements. So getting into how they prepared the injectate. So they did iliac crest, the posterior superior iliac crest, fluoroscopic or ultrasound guided harvest with a heparinized syringe, 1,000 international units per ml of bone marrow. A total of 6 to 8 sites, 3 to 4 per side, were used to harvest 60 to 90 mLs of bone marrow aspirate, obtained 5 to 15 milliliters per site to maximize the recovery of progenitor cells. The resultant BMA bone marrow aspirate was manually processed in 2 to 5 ml bone marrow concentrate by trained laboratory personnel using multi-step centrifuge 200 G for 6 minutes, and subsequent isolating compact central layer of nucleated cells within biosafety cabinet and surrounding the clean room environment. They published their specifics elsewhere. You could just look at the link. And in addition, they had 60 mLs of anticoagulated whole blood, which was obtained by a venipuncture to manually prepare PRP. The blood was centrifuged 200 Gs for 10 minutes to isolate leukocyte poor plasma, which subsequently centrifuged 2,300 Gs for 6 minutes to collect platelets for resuspension in reduced plasma volume, 3 to 4 mLs, or 15 to 20-fold reduction in volume. A portion of the PRP was frozen at negative 80 degrees Celsius and thawed to prepare the platelet lysate. The patient was placed supine with the knee being treated 45 degrees of flexion under fluoroscopy. Biplanar view contrast was used to confirm appropriate interligament needle placement, encouraging that flow contrast pattern of both anterior medial and posterior lateral bundles of the ACL traveled between the radiographic insertion of the original landmarks. If not achieved, the needle was redirected. Once placement was confirmed, 2 to 3 mLs of equal mixture of BMAC, PRP, and platelet lysate were injected directly into the ligament. The needle was subsequently withdrawn from the ligament, and while still in the joint, approximately 2 to 4 mL of equal mixture of PRP and platelet lysate along any remaining BMAC was injected into the intra-articular space. No bracing was required. All patients were encouraged to follow the following rehab protocol and participate in activities as tolerated. Patients were directed to refrain from activities that caused more than 2 out of 10 pain for the duration of the rehabilitation. For the first month, patients were directed to perform range of motion exercise, light strength training, and balance training while the knee was protected. Afterwards, 5 to 12 weeks, patient participated in resistance training targeting the hip abductors and hamstring with light squats and leg presses, along with core strengthening using a balance board. If not experiencing pain, straight jogging, single leg exercise, and progression to combo strength balance exercises were encouraged. Over the next 8 weeks, that's weeks 13 to 20, patients began guided sport-specific movements and non-cutting sports. Finally, week 21 to 52, the Santa Monica Sports Medicine Prevents Injury, an enhanced performance program was recommended and ultimately returned to full sport only with physician clearance. So the article has great pictures of fluoroscopic guided ACL injections. I mean, this is a great article. I'm going to probably incorporate this into my practice because I have been ACL. First of all, I don't see a lot of ACL tears in my practice. A lot of them make it through ortho before they get to me because we're in one of those large multi-specialty buildings. But there are patients like myself who really don't want surgery, and if you can afford it, I mean, this is amazing, right? You just have to be patient. Then again, surgery is not such a quick fix either when it comes to the ACL. It's a long rehab. So I think the knee-jerk reaction for surgical repair needs to be revised. I give kudos to Dr. Centeno and his team. This is really a great study, and I look forward to hearing more from them and learning more and sharing that information with everyone listening here. So please, if you enjoyed the podcast, please share it with your colleagues as well as rate it on iTunes, Apple, Stitcher, whatever you listen to, Google Play. And I hope to see you guys at the courses and conferences. The pain management world is a small world, and it's getting smaller with all these international meetings, and it's really great to meet all of you guys. Thank you for listening. And as a thank you for listening, if you're interested in board prep or any of my online activities, use coupon code PAINEDU for 20% off. And I hope to meet you in person. Take care.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.